My name is James Curtis. I did this project with Georgia Lawrence. This is for SPCE 611 at Ball State, and this is our project replication PowerPoint presentation, and our study was over the TeachBack method and using that to teach others new skills. We're going to begin the presentation off by looking at supporting literature for the TeachBack method. The first piece of supporting literature that we are going to look at is an evaluation of the TeachBack method for training new skills. This is the original study that inspired the replication project for this class, so stay tuned towards the end of the presentation and you will see our results when we replicated this study. The TeachBack method is defined in the article as involving a teacher explaining one chunk of information at a time and then asking the patient to repeat it back to them using their own words. They ran the study with 13 undergraduate students from the University of Florida. The results of the study was that the TeachBack effectively increased procedural integrity with the participants. Just a little side note, procedural integrity just means that the participants were able to reach mastery criteria when they completed a task. Our second piece of supporting literature is from the article, The Effect of the TeachBack Method on Knowledge, Performance, Readmission, and the Quality of Life in Heart Failure Patients. The objective of the study was to determine the effect of TeachBack education about the knowledge, practice, readmission, and quality of life in patients with heart failure. The sample size of the study was heart failure patients enrolled in a medical center in Tehran. The main result from the study was that heart patients retained information from up to 3 months from discharge, and it states that the patient on average has doubled their knowledge since the TeachBack intervention was introduced. This is important because they wanted to teach more independence and kind of just promote healthier living for heart patients, so that way they can improve their quality of life while also decreasing the chances that they need to come back for readmission, which means that the hospital can keep their numbers lower and they don't have to be overpopulated and ran thin, and they could take better quality of care of their patients.
The next piece of supportive literature that we found is from an article called Utilizing the TeachBack Method to Improve Surgical Informed Consent and Shared Decision Making, a review. In the healthcare field, patient education plays a large role in effective treatment. It's imperative that patients understand treatment procedures, aftercare, and decision making. In the article, it stated that studies analyzing the use of the TeachBack in medicine have demonstrated its effectiveness and benefit to patient care. So if patients have a better understanding of their treatment procedures and aftercare, we're going to see a decrease in patient numbers at a hospital or like emergency medicine and stuff like that. The article also stated that further studies on the use of TeachBack to improve preoperative informed consent is supported by the few preliminary trials showing a positive effect after implementing the TeachBack method in clinical patient interactions.
My last piece of supporting literature that I found about the TeachBack method is an article called Effectiveness of the TeachBack Method for Improving the Health Literacy of Senior Citizens in Nursing Homes. The goal was to give a vulnerable group in China and to see if we can improve the knowledge that they have will assist older adults in self-management and better self-care. The method was taking different nursing homes and splitting them in different groups by size. So an example would be a large nursing group, a medium, and then a small sized one. After they split them again with half using the interventions of TeachBack and the other half just being a control group, not adding any interventions. After 6 months of collective health literacy, education, and intervention, the older adults from the nursing homes in Urumqi all showed significantly increased health literacy scores as well as improved scores across the 4 dimensions they were testing.
Our last piece of supportive literature is from an article named The TeachBackMethod, Using a Nursing Education Intervention to Improve Discharge Instructions on an Adult Oncology Unit. Within this article, it discusses the TeachBackMethod and how it can help individuals increase their health literacy and discharge instructions. Health literacy is when individuals have the ability to obtain, process, and understand basic health information to make informed decisions. A lower health literacy increases the healthcare costs, risks of chronic illness, and decreased use of preventative services. Within the article, it states, the TeachBack is not a health literacy test. It is a learning strategy that can help to mitigate low health literacy issues. TeachBack allows healthcare providers to confirm comprehension and re-educate patients if needed, and it reduces the risk of patient misunderstanding. Any member of the healthcare team can use this method, which encourages the use of open-ended questions, decreases fear or discomfort for the patient, and can be used in all patient education situations. In addition to promoting health literacy and stronger communication, the TeachBack method allows patients to directly participate in their learning and care. This also allows patients to make more informed decisions about their care and how to move forward with any results or something like that they're receiving.
Now that we are finished going over the supporting literature, we are going to go back and go over the purpose of the original study, and then more importantly, the purpose of our replication study. The purpose of the original experiment was to evaluate whether TeachBack is a practical training procedure to teach participants a new skill. So the purpose of our study is to see if we can replicate the study with different participants, but also with a different setting since we are completing the study online instead of in person like the original study.
So the methods for our study are going to be broken down into 4 separate parts: materials, setting, participants, and the design. For our materials, we were required to have skill instructions, a paper for data collection, an extra piece of notebook paper to take some extra notes if we needed to, a pen, and then all of the stimuli that we used. So we used Play-Doh, stuffed animals, fidget toys, balls, books, animal figurines, and then some toy car figures as well. The setting that we replicated our study in is a one-on-one setting, and we utilize Zoom and FaceTime a lot throughout our replication process. For our participants, James is a male, age 25. I'm a female, age 23. We were the only 2 participants, and we're both graduate students with some knowledge in ABA. And then the design that we used is a multiple baseline design. Our targeted behavior for this replication is efficiency, and the definition that we came up for this one is following or implementing the steps of a given instruction with 1 or fewer errors by completion. An example of efficiency is Georgia is told to wash her hands and misses the step to throw the paper towel away. Another example would be James is told to brush his teeth and he completes the task without any missteps. A non-example would be Georgia is told to wash the dishes. She does not rinse the dish, use soap, or place it on the drying rack. And then another non-example would be James is told to do the laundry. He does not add soap to the washer and forgets to use a dryer sheet.
Data collection for the project. Data was collected over Zoom or FaceTime multiple times a week. One group member would watch and record the number of total steps along with correct steps, while the other team member would complete the task. Both members followed a step-by-step instructions list to grade the task, but also to complete the task. For IOA purpose, random sessions would be recorded and both team members would grade it to make sure that they were similar in their grading to ensure accurate data. Design. For our graph design, we use multiple baseline design, also known as MBL. That is the graph where you have two graphs stacked on top of each other, and then you use the dog-leg lines from the top graph all the way down to the bottom graph. This graph is useful for interventions that are irreversible due to learning effects when treatment can't be withdrawn. Once we moved past baseline to post-teachback and feedback, which are the three intervention changes in our graph, those interventions are irreversible to the participant because they gain more knowledge during that and cannot simply forget it and revert back to baseline.
So now we're going to talk about our baseline phases. During our baseline phases, each participant was instructed to read the written instructions for 3 different preference assessments: multiple stimulus with replacement, multiple stimulus without replacement, and paired stimulus preference assessment. When each participant stated that they had finished reading the instructions, they were instructed to demonstrate the skill to the best of their ability. All necessary materials were available to the participant to begin the demonstration. The participant could only refer to written instructions. The experimenter would not add anything else or answer any questions. Throughout this phase, there were no consequences for correct or incorrect responses. Now we're going to get into our treatment phases. During the treatment phases, each participant read the instructions for as long as they needed and began to perform the skill. The teach-back procedure was then implemented. This included the experimenter asking questions to the participant to check for understanding and correcting any information by explaining the steps in different terms for better understanding. For every correct answer, the participant was told that they were correct, and then for every incorrect answer, the participant was informed that they were incorrect and was told the correct response. These steps would be repeated until the participant could answer all questions correctly, and after this, they would run the same test on the preference assessments that were performed in baseline phases. Once the preference assessment had been conducted, the experimenter would give credit on the steps that had been implemented correctly and provide feedback on the steps that were implemented incorrectly.
IOA and treatment integrity. The IOA was collected over the first 2 sessions of the first task. After that, we did the first 3 trials of the next 2 tasks. We took the number of correct steps over total steps, and then we multiplied that by 100. For treatment integrity, we achieved this by designing a step-by-step instruction that would be used for different tasks. We would use this for running the targets, but also for grading each other, and we both created the step-by-step list and agreed on the steps that they were accurate and good to use for grading/following instructions. This is James' result for multiple stimulus with replacement preference assessment. You can see in the baseline, my mean was 79% and range was 14. Post-teach-back mean was 91%, and then the range was 15. And the feedback was 100% for the mean and 0% for the range, meaning the highest number was 100, lowest number was 100, so the range is 0. As you can see, mastery was met, and positive feedback was still provided to ensure maintenance of the preference assessment implementation.
Here are the project replication results for Georgia's MSW, or multiple stimulus with replacement. As you can see, the baseline average for correct steps throughout this preference assessment is 82.6%, with that range being 10%. The post-teachback average is 95.4% with a 15% post-teachback range. And once we get into feedback, the average is 100% with a 0% range for that one. As you can see, once we got into trial number 8, we still continue to implement the post-teachback and feedback just to be sure that the skill set for that preference assessment is still being maintained across multiple trials.
This is James' data for multiple stimulus without replacement. You can see that the baseline mean was 71%, the baseline range was 9%, the post-teachback mean was 82%, the teachback range was 17%, feedback mean was 97%, and the feedback range was 8%. You can see that using the teachback and feedback that the graph is increasing. On trial 12, we did have a dip down, but for the most part, the data is consistent and the graph is stable.
Here's the graph for Georgia's multiple stimulus without replacement, or MSWO. Within this graph, you can see the baseline average is 78% with a range of 17% within that baseline phase. In post-teachback, the average is 96.4% with a range of 9. And once we get into feedback, again, the average is 100% with a 0% feedback range. You can see in this graph that it's a steady increase in the skill set for Georgia. Again, once we got to trial number 8 and she reached 100%, we still continue to implement the post-teachback and feedback, again, to maintain the skill set for that preference assessment.
And lastly, for James, we have his data and graph for the paired stimulus preference assessment. You can see that the baseline mean was 72%, the baseline range is 20%, the post-teachback mean was 86%, post-teachback range was 30%, feedback mean was 100%, and the feedback range was 0%. And I don't know if you've noticed, but James's baseline has been longer than 5, and just for a reminder, that is because we're using the multiple baseline design graph, so one of our graphs needs to have more baseline.
And here we have the project replication results for Georgia's paired stimulus. The baseline average for Georgia with the paired stimulus preference assessment was 68%, and the baseline range is 20%. For post-teachback mean, 94%, and post-teachback range, again, 20%. Once we get into feedback, the average is 100% with a 0% feedback range.
Limitations. One limitation we faced was the setting of doing this project over Zoom and meeting on FaceTime. This made data collection harder compared to the original study. That is because we had to fight with lag, timing issues, camera angles, and etc. And just a side note about the camera angles, we were running these targets of preference assessments, so we had to make sure that all the items that we were using were in the camera angle while also the other participant, so they could show that they were following the instructions correctly. Our biggest limitation is the number of participants we had compared to the original study. We only had 2 members compared to the 13 of the original study. Because of this, we had to run the task more times than the original study, and this led to the replication of the study having a higher trial count than compared to the original. Because of this repetition, we did improve our skills naturally from the process of completing the same task over and over again, and this is a huge limitation because this could skew the data that we saw previously.
In conclusion, across both participants, mastery criterion had been met consistently by the feedback phase. Based on the data collected, the TeachBack method was effective for 3 different preference assessments across 2 different participants. Because we're targeting efficiency for both participants were calculated by referencing data collection for completing the steps of a preference assessment with 1 or fewer errors in a trial. And the average trials for Georgia to reach efficiency was 7, whereas the average trials for James to reach efficiency was 9. We had James complete more trials in baseline for multiple baseline design and graphing, so that's why you'll see a few extra data points for him there.
Contribution log. James did 3 supporting literature, the purpose, data collection, design, IOA and treatment integrity, James graphs, and the limitation. Georgia did 2 supporting literature, methods, targeted behavior, baseline phases, treatment phases, Georgia's graphs, conclusions, and she is also responsible for the recording. And on our last slide are all our sources that we used to help complete this presentation. Thank you.